Good evening, everybody. It is indeed a very proud privilege for all of us here at the IFS Quiz Committee team and the SIG conveners to be welcoming you all for this third episode of the second season of Genius Junction. So, Genius Junction is a nice project which IFS has come with, whereby we are conducting monthly quizzes. And this season, we are tying up with one SIG or two SIGs in every episode, and we'll be having a lecture on the subject from a very senior member of our team, and this will be followed by the quiz which will be done on Kahoot. Today the topics are PCOS and endocrinology. And let me welcome first Dr. Neeti Tiwari. Dr. Neeti is the convener of SIG, reproductive endocrinology.
PCOS, Dr.
Sorry. So Dr. Neeti Tiwari is a senior consultant at Sir Gangaram Hospital looking after the IVF unit. And she is the convener of special interest group on PCOS. And we can't wait to hear from you, Dr. Neeti Tiwari. So without any further ado, I invite you to come over and enlighten us.
Thank you so much for the kind introduction. So today, I'm here with a topic which is so very relevant in our practice: adolescent polycystic ovarian syndrome. We come across so many girls who come up with these complaints, and not only in our clinical practice, even in our family, amongst our relatives, so many questions when these young girls have symptoms and they don't know what to do next. So, we will be talking about adolescent polycystic ovarian syndrome today. So, WHO defines adolescence as a period between 10 to 19 years of age, and this is a very important period because it lies between the childhood and adulthood, and it includes significant changes in the growth, development, and puberty. In this age group, the body image, sexual identity, peer interaction are critical for the evolving personality. And 6 to 18%, that high. So in my practice, if I recall, around 15% of girls, they usually are affected by PCOS. Timely diagnosis and medical intervention of PCOS may prevent health sequelae and contribute to psychological well-being. So, most of my talk is derived from this international evidence based guidelines for the assessment and management of polycystic ovarian syndrome, which was a combined effort of ASRM, Endocrine Society, ESHRE, and European Society of Endocrinology, along with Monash University. So, as we know, the previous guideline, which came in 2018, that talked about accurate diagnosis of PCOS, care, prevention of complication, and all that, it was these 2023 guideline which also talked about elimination of specific unnecessary tests, which is very important, that we should know what tests are required, and importance of identifying adolescents which are at risk of PCOS, may not have full blown but at risk of PCOS. So why so much of ado about the diagnosis of PCOS in adolescents? Because the Rotterdam's criteria, which we normally use for diagnosis of adult PCOS, it says that there should be any two out of these three features present, that is oligo or anovulation, hyperandrogenism, either clinical like acne or hirsutism, or biochemical, and polycystic appearance of ovaries on ultrasound. So these three features, unfortunately, they overlap with the features of normal pubertal development. So in the initial pubertal period, the cycles will be irregular, there will be acne, some amount of hirsutism may also be there, and ovaries may appear polycystic, which is absolutely normal. So that's why there is always a dilemma of how to diagnose adolescent PCOS. So the consensus is that the diagnosis of PCOS in adolescents require both ovulatory dysfunction and evidence of androgen axis. Then only we can say that a girl has PCOS. At the same time, there are some girls which are at risk of PCOS. They may not have full blown both the criteria meeting, but they still have one or the other feature, and they are called those at risk of PCOS. And when we read about the diagnosis of adolescent PCOS, it is very important to avoid misdiagnosis, delay, under or over diagnosis, and eliminate unnecessary investigation in these young girls. So when do we consider cycle irregular in adolescent? This is a very important, slide which we should always remember, that the first 1 year after the menarche, the cycles will be irregular. We don't have to bother. After 1 year, up to 3 years post menarche, if the cycles are less than 21 days or more than 45 days, then only we call them irregular. After 3 years of post menarche, if they are more than 35 days delayed, then also we call it irregular. And more than 1 year post menarche, at any point of time, there is a amenorrhea of 3 months, we call it irregular cycle. So we should know what is irregular. And then when we talk about clinical hyperandrogenism, comprehensive history and examination is very essential, because mild acne and hirsutism, as I've already told, is common at puberty. So when we are trying to look for PCOS, we are basically, there should be moderate or severe comedonal acne, 10 or more facial lesions to call it significant. Hirsutism, if we are looking for hirsutism, we should not go just like saying that it looks like the girl has extra hair. No, we should go by the modified Farriman Galway score, and if it is more than 6 to 8, we call it significant. And clinicians should be aware of potential psychosocial impact of hirsutism on adolescents. So even if we find that the score is less, but if the girl is troubled, we need to address it, right? So, when we talk about just a revision of a modified Farriman Galway score, so we are looking at these 9 body areas: the upper chin, the lower chin, the chest, then the upper abdomen, lower abdomen, and then so on and so forth. And then, we have to see the amount of hair which are there, according to which we give the score. And score of more than 6 to 8 becomes significant. So, this is how, the hirsutism in young girls will look like. And when we are talking about acne, the first picture is showing the comedonal acne, and the second one is showing the pustular acne. And as I told you, more than 10 lesions if present on the face, we call it a significant acne. Then what about biochemical hyperandrogenism? When should we start looking for hyperandrogen biochemical in the tests? This is only when clinical hyperandrogenism is not detected. Let's be very clear on this. If a girl already has hirsutism, if a girl already has a significant acne, no need to do any tests to look for testosterone levels, DHEAS levels. Don't do that, please. So it is only required if you don't find a clinical hyperandrogenism, and because you want to make a diagnosis of adolescent PCOS, which requires both hyperandrogenism and ovulation, that's why you need to do a clinical parameter. So calculated free testosterone and free androgen index should be used in the diagnosis of PCOS, and always should be a morning sample. When we are doing testosterone, please check that the lab is doing high quality assays like liquid chromatography, mass spectrometry, and extraction immunoassays. Other, not ELISA. The many labs which do ELISA, which are not very accurate. And when do we do androstenedione and DHEA? Because what, sometimes we see that people just give a list of battery of tests to girls, not even knowing what we are going to gain from these tests. So when do we need to do androstenedione or DHES? That is only when we require to exclude adrenal source of androgens, like in congenital adrenal hyperplasia or adrenal tumors. And when do we suspect these lesions? These lesions we suspect if there is a very significant hirsutism or virilization, or if you find that there has been a rapid increase in lesions, then only you start thinking in terms of adrenal tumors or testosterone in case of ovarian tumors. Otherwise, you will, if you find hirsutism or moderate acne, you don't need to do these tests. Only when there is no signs, then only you will go for looking for biochemical hyperandrogenism. What about ultrasound? Is there any role of pelvic ultrasound? So the evidence says no. Ultrasound should not be used till 8 years of postmenarche for diagnosis of PCOS due to high incidence of multifollicular ovaries. So you can see in the above picture, this is a multifollicular ovary, which is a very common finding, normally present in a pubertal, girl in adolescent period. So we will not do ultrasound in them. Also, that we are not able to do a transvaginal scan in adolescent girls when they are sexually inactive. And if you go for a transabdominal scan in these girls with so much of obesity, you're not able to actually see the ovaries very well. So there is no need to, go for a pelvic ultrasound just for the diagnosis of PCOS. But again, at the same time, if you are finding, if you're suspecting an ovarian tumor because there is significant virilization, or there is a sudden onset, there is an increased rapidity of hirsutism with which it is developed, and you're looking for an ovarian tumors, then of course you can go for a ultrasound. Otherwise, for diagnosis of PCOS, ultrasound is not required in a adolescent age group. What about hormones? Although serum EMH is a significantly higher in adolescent, it is not recommended as a single test for diagnosis of PCOS. So please don't order AMH in adolescents. Serum FSH and LH testing is not required because we are not going to gain anything from that, neither in diagnosis nor in the management. What is important is that other causes should be excluded of the anovulation, like hypothyroidism, hyperprolactinemia. So for this, you can do a thyroid profile in these girls. You can do a serum prolactin levels. Yes. And if you are, as I have already told, if you're suspecting non-classical congenital renal hyperplasia or adrenal tumors, then you can go for 17 alpha hydroxyprogesterone or GDHES levels. Now, as I earlier also mentioned about these adolescent at risk of PCOS, these are women, these are girls which do not have frank, both the criteria meeting, but they have features, and that put them into an increased risk group. So these girls need to be followed first thing. They need to be followed later if they develop into full blown PCOS. And secondly, whatever complaint they come with, that needs to be addressed. For example, if a girl has irregular cycles but does not have hyperandrogenism, it doesn't mean that we, do not treat her for irregular cycles just because she hasn't come into, or the other way, other vice versa, has hyperandrogenism but cycles are regular. Then also she needs to be treated. So whatever symptoms she comes with, they need to be treated and at the same time followed up for the development of full blown PCOS. Now, another very important thing which we often miss in these girls, because when we are talking about adult PCOS, we always remember that okay, I have to get a lipid profile done, I have to do a oral GTT, I have to look for blood pressure. In these young girls, suppose a 17 and 18-year-old girl is coming to my OPD, I might just forget to check her blood pressure also. So this is very important evaluation of comorbidity. Remember, these young girls can also have higher blood pressure or a deranged sugar profile. So very important to look for oral GTT to do this. And also at the same time, because this is a very very sensitive period, adolescence, there is increased evidence of depression, anxiety, body image issues because they are often obese, and eating disorders in adolescent PCOS. And early identification and management becomes of utmost importance in these girls. So now coming to after diagnosis. So diagnosis we have made, we need both anovulation and hyperandrogenism. Hyperandrogenism can be clinical, or if clinical is not present, I will go and check for biochemical hyperandrogenism. And I will establish a diagnosis of adolescent PCOS. Those who do not fit into adolescent PCOS, I will keep them in an at-risk group and treat them also for whatever symptoms they have come with. So when we talk about management of adolescent PCOS, as I told you, a definitive diagnosis is not required to just initiate the treatment, just go symptomatically and treat them and do a long term follow up. So, what are the basic premises on which we treat adolescent PCOS? First is lifestyle management, then combined oral contraceptive pills, metformin, and anti androgen. So, these are the four main things which we use in our armamentarium to treat adolescent PCOS. So, when we talk about lifestyle management, it is a multi component lifestyle interventions including diet, exercise, and behavioral intervention in overweight and obese girls. Achievable goals like 5 to 10% weight loss over 6 months could result in significant clinical improvement, and that is what we should target. Never give them very hard targets. And what they talk about in this guideline 2023, a very nice word which they say smart. Smart is specific, measurable, achievable, realistic, and timely. Such should be the goals of lifestyle management. And self monitoring is emphasized. So don't just tell them to go and lose weight. Please tell them clearly what you are expecting out of them, how they are supposed to lose the weight by diet and exercise. So when they talk about dietary management, balanced diet and healthy eating principles for all, we have to tell them to avoid junk food because these adolescent girls are fond of eating pizza, burger, cold drinks. So we have to tell them that how harmful these things are for them. So and to increase greens in their diet, to add proteins in their diet, so make it more balanced diet and healthy eating principles. At very young age only, we should tell them, that refined sugar is like poison for you. You have to remember this for your lifetime, that you have to avoid using refined sugars in diet in any which form. And when they are looking for weight loss in obese girls, we have to tell them that there has to be an energy deficit. We have to tell them the concept of energy deficit, that what you are eating and what you are spending, there has to be a deficit in that. Okay, so 500 to 750 kilocalorie of deficit is required. And how you calculate that, you have to do it for them. And then allow flexible and individual approach to reducing energy intake. Avoid unduly restrictive and unbalanced diet, because this is what we very often see, because these girls are struggling so much with their body issues, image issues, that they stop eating breakfast, start skipping their dinner. That is not how they are going to lose their weight. You have to tell them that it has to be a does not have to be unduly restrictive. It has to be a gradual process. Okay. Then, in exercise for prevention of weight gain in adolescents, 60 minutes of moderate to vigorous intensity physical activity per day, including those that strengthen bone and muscles, 3 times a week has to be done. So, 1 hour of moderate to vigorous intensity exercise is required per day in these girls. And what we have to tell them, that otherwise also they should minimize sedentary or sitting and screen time. So while they're studying, we can tell them to walk, don't sit for a long time. We have to tell them not to take rickshaw to the metro station, maybe just walk down to the metro. These are small little things, which behavioral changes which they can make in their day-to-day life, so that they can include more physical activity in their day-to-day activity. And self-monitoring with fitness tracking device, if you give them, that also kind of encourages them to go ahead, do more physical activity with time. Now, after this lifestyle management, which is very, very important, remember the first thing, and we have to be very, very objective in telling them what we expect from them in when we are talking about lifestyle management. Now, let's come to the pharmacological management. So, what we are supposed to do. So, one thing which has come up in big way is combined oral contraceptive pills in adolescent PCOS. So, it is recommended in adolescents with established diagnosis of PCOS, as well as those at risk for management. So, which I talked about, at risk girls also, for management of irregular cycle and or hirsutism. So, combined oral contraceptive pills can be given, and we can easily give them after the age of 15 years. No specific types or doses or of estrogen, progestins, or combinations are recommended, and we try to give a low dose of estrogen always. So there is no specific type or doses you have to look for, any fancy COCPs. The easily available combined oral contraceptive pills can be given to them. Duration, how long do you give? It is not very well defined, but normally what we do in our practice, because you will start the lifestyle management also, where you will try to reduce the weight of the girl also. So sometimes with that only their cycles become regular. So after 1 or more years of COCP, you give a trial of COCP, you stop it for a while, see if the spontaneous menstrual regularity returns. So that is how you go about it. So after 1 or 2 years, you can stop it and see if the spontaneous cycles come. Then, what about metformin? Can that be given in adolescent PCOS? Yes. In combination of COCPs, you can give metformin, especially if the lifestyle changes are not able to bring out the desired goals and the BMI is more than 25 kg per meter square. Metformin, in addition to lifestyle, could be considered in adolescent with the diagnosis of PCOS or those at risk. So in those who are really obese, you don't have to wait for the lifestyle changes to for 6 months and then add metformin. You can add metformin from the very beginning also. And it also offer greater benefit in those patients if where you find an impaired glucose intolerance. You start at a low dose in these girls with 500 milligram at the night, then you can start gradually increasing it depending upon the response. Give an extended release preparation which has less side effects, and the maximum dose which can go in an adolescent is 2 grams. Gastrointestinal side effects are mild and self limiting, and they appear safe for long term use. So, metformin can be safely given for a long term use. So, when we talk about COCP and metformin, COCP definitely are better than metformin when management of hirsutism with irregular menstrual cycle is concerned. But if there are metabolic indications like obesity, like deranged metformin is definitely a better drug over COCPs. And when there are irregular cycles, also you will combine both of them, right? And where COCP is contraindicated, not accepted or not tolerated. So one very important thing here I want to tell you is that when you are giving combined oral contraceptive pills in young girls, please remember the general principles on which we give combined oral contraceptive pills. So if the girl is very obese, you have to be careful about the risk of venous thrombosis. So all those things has to be remembered. So in some women, some girls, COCP may be contraindicated, so or not accepted or not tolerated because they could be associated nausea with it, or maybe the societal, because of the societal pressure, they're not able to take combined oral contraceptive pills. Their metformin may be considered even for irregular menstrual cycle and for hirsutism, but remember that it is a poorer drug as compared to oral contraceptive pills for these indications. What about progestogens? Let's not forget this molecule because we have used it for so many years now in adolescent girls. Progestogens or natural micronized progesterone, where suppose the girl has irregular long cycles but normal menstrual bleeding, she does not want to take contraceptive pill. You can even give them progestogen, and you have to basically give a total. If you're giving medroxyprogesterone acetate or norethistron, total dose of 100 milligram has to be given. So it can either be given as 10 milligram daily or for 10 days, or it can be given as 10 milligram twice daily for 5 days. Okay, and when do you give it? You can give it any time from 20 to 30 days after the last menstrual period. So depending upon how many cycle the girl wants, basically what we have to target is that she should have at least 8 menstrual cycle in a year. So if she wants a delay, doesn't want 12 menstrual cycle, it is perfectly fine. You can give it in a later date. So this is how you give it. And if there is no withdrawal bleeding, then of course there could be a thin endometrium, or you have to rule out pregnancy even in adolescent girls. Suppose this girl has irregular long cycles along with prolonged or heavy menstrual bleeding. She has significant heavy menstrual bleeding which is causing anemia. In that case, only giving progestogen for 5 or 10 days may not help. You may need a continuous progesterone, or you may even give a progesterone only pill, though it is not described very well. It is mentioned in the guideline but not described very well. But you can give progestogen for a longer period. And if this progestogen for a longer period is also not bringing the change in bleeding and still the patient is bleeding heavy, please rule out, even in these adolescent girls, go for a vaginal examination if she allows or the parent allows, to rule out any polyp there, or you can get an ultrasound done now for a submucous fibroid or polyp. Now, coming to anti-androgens. So, for as we discussed, for hirsutism, basically COCPs, the combined oral contraceptive pills with cosmetic therapy, are tried initially for the 6 months before considering anti-androgens. So that is the first line. Remember, required where COCPs, but anti-androgens may be required where COCPs are contraindicated or not tolerated to treat hirsutism directly. You might give anti-androgens. For moderate to severe, suppose a girl already has a severe hirsutism, when you are starting her on combined or oral contraceptive pills, you can start anti-androgens concomitantly. You don't have to wait for 6 months in severe hirsutism cases. So spironolactone is a potent anti-androgen which can be given in combination with COCPs and metformin in doses of 25 to 100 milligram per day. The other anti-androgens which we know of, finasteride and flutamide, they are associated with increased risk of liver toxicity. They are avoided in adults and they are avoided in adolescents also. So basically, the OCPs which contains anti-androgenic drosperinone, so it comes with the name of Yasmin, Yamini, Dronis 30, Crescenta. So this is basically drosperinone is structurally related to spironolactone, so works as an anti-androgen. It can be given. Then cyproterone acetate, a very favorite molecule of lot of gynecologists, comes as Diane 35, Jeanette 35, Crimson 35. So here, remember that the Ethinyl estradiol is basically 35 microgram, and cyproterone acetate is 2 milligrams. So it's a bit higher dose of ethinyl estradiol. This combination should always be considered as a second line therapy after the combined oral contraceptive pills. If they have not worked, you can, so many a times, physicians are in habit of giving it as a first line therapy for hirsutism or acne. Remember, this should be taken as a second line because it has its own share of side effects, including venous thromboembolism. So always a second line. If you feel that the normal contraceptive pills are not working, the lower dose estradiol are not working, then you will think about giving this combination. And spironolactone I have already talked about, 25 to 100 milligram can be given. So, just briefly about management of hirsutism in the end. So, pharmacological intervention we have talked about, combined oral contraceptive pills, anti-androgens. Then topical therapy can also be used. Then cosmetic measures, very important, waxing, shaving, plucking, and then the direct hair removal measures like laser therapy and electrolysis. So let's be familiar with this molecule. Many girls, nowadays they use it, which is called efluorethene hydrochloride. It is 13.9% cream. It is FDA approved. It's an irreversible inhibitor of ornithine decarboxylase, which is the enzyme essential for hair growth. So the effect it seen in 4 to 8 weeks, that it takes that much of time. BD application at least 4 hour apart is done. The only problem is that once you stop using it, there is a reversal of hair growth within 8 weeks of discontinuation. So this is a topical therapy in those girls where you cannot give oral, or you want to combine it with that also. Oral anti-androgens can be done. Then mechanical laser and light therapy, many girls are doing using this now. Not only reduces facial hirsutism, but also therapeutic for related depression. Imagine a girl, which I showed the picture in the beginning, with so much of hair in the upper lip area, or because of this, there is a related depression, anxiety in their life, and the quality of life improves dramatically after this laser therapy, where their skin clears. So more treatment, but these girls, remember, will require more treatment session in PCOS girls. And there is a mechanical hair removal with intense pulse light therapy also could be considered, but benefit are less pronounced compared to the laser treatment. And coming to the psychological therapy, very important. There, as I have told you again and again, please spend time with them, spend time with the family, tell them what the child might be going through. Let's not body shame them. Let's not tell them that you're not able to lose weight. We have to be very, very tactfully handle them, so that they are able to fight this problem of PCOS. The lifestyle intervention, other therapies, as they start taking effect, 6 months, 5 months, 6 months, once the COCP, the lifestyle management start showing effect, they will improve psychologically also. And very, very rarely they might require any, full blown antidepressant treatment. They usually improve as their symptoms improve. So this ACOG recommendations, again, it was given by in 2019, where they said that hirsutism and acne should be taken seriously. And don't say that, if you feel that the number of hair is less and the girl is bothered, you have to still address it, because it has an effect on their self-esteem and quality of life. There's no clear consensus guidelines on the diagnostic criteria within 2 years of menarche. So hold on. Don't be in a hurry to give them to label them as PCOS. Don't be in a hurry. Give them time to grow and get through this periods of adolescence. Some may continue to become at-risk girls, will become full-blown PCOS. Some may just improve with time. And as I told you, finding of polycystic ovarian morphology is a very common. 30 to 40% girls will have it. So pelvic ultrasonography again is not routinely indicated unless serum androgen levels or degree of virilization is concerning for an ovarian tumor. Okay. So how do you follow up a girl who has PCOS? Wait once a week. Early, ensure that the menses at least every 40 to 45 days. So please tell them to maintain a menstrual calendar, and this has to be emphasized on them, that it is not for today, it is not for the next 1 year, it is for the life till they attain their menopause. They have to maintain a menstrual calendar and keep a watch on their menses, that they are coming regularly, because if they have a long period of amenorrhea, they're likely to get into endometrial hyperplasia. Then oral GTT yearly. Remember, in these young girls also do oral GTT yearly, and BP yearly, and lipid profile yearly. Okay, let's not miss on these metabolic profile in these young girls. So to conclude, normal pubertal development to be kept in mind while diagnosing PCOS. Diagnosis of PCOS in adolescents currently hinges on ovulatory dysfunction and androgen axis. Those at risk should be treated symptomatically and followed up later. Avoid unnecessary investigations. So I told you there are hardly any investigations which are required. So please get out of this habit of just writing the battery of tests, DHES, androstenedione, DHEA, DHES, both, you know, and only where required, you will please write these investigations. Management of adolescent PCOS begins with lifestyle modification and COCPs for correction of menstrual irregularity and clinical hyperandrogenism. If required, metformin is added in overweight and obese girls and those with impaired GTT. Counsel the patient and family regarding the long term health effects of PCOS. Counsel them that this disease stays with you and you have to take care throughout your life, at least till the reproductive age group. Thank you so much.
That was an excellent talk, Dr. Neeti. In a very brief time, you managed to cover what all is what, because when you read the guideline, we don't know what to give emphasis to what.
Yeah,
Because that's when you look at the recommendations that are around, it runs around 250 pages, so you just get bogged down. And you very nicely brought out what we are supposed to do and what we should definitely not do.
yeah.
Yeah,
Thank you so much. Thank you.
yeah.
Thank you, Dr. Padmaj.
And I think people will come out with questions as we go ahead. And you'll be around, Dr. Neeti. If there are any questions, you can answer.
Sure, sure. I'll be here for another half an hour.
Uh, One thing I find is this. Ultrasound, we are not going to do it for diagnosis of PCO, but most of the women, I mean the girls and the mothers, they're happy if you do an ultrasound, because we're not really missing something serious. Because sometimes they have these big functional cysts. At least one or two of my kids, underwent torsion and all that. Then they said, I mean, in retrospect, they will say, if the scan was done when she was complaining, you would have picked it up
Yeah,
and
yeah,
not landed up.
absolutely, Dr. Padmaja. Absolutely agree. But what is important is
We don't
ultrasound
diagnose,
can be done for, but not for diagnosis of PCOS.
not for diagnosis, and we shouldn't label them as
Yeah,
anything.
yeah,
Yes.
yeah, yeah, yeah.
Hmm?
Not on the basis of that you will label them PCOS.
Yes, yes. And I think writing down all your ultrasound findings, not just write that uterus is normal, ovary multiple small follicles, endometrium this big, diagnosis PCO. It shouldn't be like that. So
Yeah,
someone who is reading the ultrasound report should have a visual picture of what it looks like.
yeah,
I mean, it's important to comment even on the size and whatever information you can get. Some of the girls who are not very obese, if you have a really full bladder, we can see pretty well uterine arcuate. Sometimes you pick up things like that. You can
yeah,
comment on whether the endometrium is looking hyperechoic, isoechoic, patchy,
yeah,
the variant sizes, volume. So I feel as much information as possible if it is written and handed over, because this girl, we are going to be following her till for her lifetime. So
yeah.
wherever she goes, wherever the doctor she goes, that information will be there.
Yeah. So I would just emphasize here, that if the girl has mild to moderate hirsutism, acne, which is like looks like PCOS, not very very significant,
Mhm.
don't go for androgen levels, but
Yes,
definitely do a oral GTT, do a
yes,
lipid profile. Not let's
yes,
not miss that.
yes.
That is important because I have myself across girls who have a BP of 140/90, 17, 18-year-old girls.
Mhm.
So it is very important that we do not miss on metabolic profile of these girls.
Yes.
Thank you so much, Dr. Niti
Thank
and
you so
Dr.
much.
Padmaja, for this brilliant discussion. I think now we should move on to the next talk. We are already overshooting time. Um, Dr. Puneet is with us, and we all know her very well. She is the convener of the special interest group on endocrinology in clinical practice. So I think I would request Dr. Puneet to start off with her talk. She'll be talking to us about hypothyroidism. And also, I would like her to please stick to the time. Although it's a pleasure listening to you guys, but then I think 20 minutes preferably. Dr. Puneet.
Sorry for overshooting, Dr. Manjusha. I wish you had, stopped me in between.
No, actually, your talk was so mesmerizing that I wanted to go on forever.
I'm so
I
sorry.
mean,
I'm so sorry for
it
overshooting.
was
Even
such a
I
pleasure.
realized after finishing that, I've kind of overshooted. I'm so
No, no,
sorry.
it was such a pleasure. I wish outside this meeting I could be talking to you forever, and you cleared so many of our doubts.
Thank you.
And I think we now move on to the next talk. Dr. Puneet, please. I would request our host to allow Dr. Puneet to put on her video and audio.
Hi, good evening, everybody.
Yeah, good evening, Dr. Puneet. Nice to
Evening.
see you. Yeah.
Thank you, and thank you for this lovely evening and having me here. I got the message that I have to be on time, so I will be very much on time, and I hope I convey the message which I'm supposed to. So I have been asked to speak on subclinical hypothyroidism and antithyroid antibodies. What's the implications in our infertility practice? So just let's have a little background about why thyroid hormone is important and what it is, how it is involved in our reproductive, outcomes. So we know that we all have been practicing for a while that they are closely related. Pregnancy outcomes do depend on normal thyroid hormone levels. They may have direct effect. There are various mechanism of actions. They may have direct effect on the ovaries, or they may indirectly interact with sex hormone binding proteins, and their disorders may negatively affect the reproductive function. Both hypo and hyper can lead to menstrual irregularities, infertility, and recurrent miscarriages. So what can be the cause of these thyroid dysfunction? It can be autoimmunity, again, the thyroid gland, which is called as Hashimoto thyroiditis. It can be iodine deficiency, which is obviously more common in developing world. And it could be iatrogenic hypothyroidism, where either a female has received a radioiodine therapy or has undergone a surgery for hyperthyroidism. And again, is it linked to pregnancy? Is it linked to infertility? Let's talk about it. So when we think about thyroid dysfunction, we mainly talk about two main broad subheadings, which is overt hypothyroidism and subclinical hypothyroidism. Overt, as the name indicates, it means there is a clear-cut high levels of TSH and low levels of free T4. This can lead to severe symptoms and can be associated with increased incidence of infertility, miscarriage, and some other adverse outcomes. It should be definitely treated with thyroid replacement, mainly in the form of levothyroxine. Now, what is this subclinical hypothyroidism? This is a milder form of hypothyroidism, which may or may not need treatment. There's a lot of controversy around its existence, around its treatment, around its management. It has been shown that it can be associated with pregnancy outcomes, not necessarily with infertility, but yes, with pregnancy outcomes. So what is this subclinical hypothyroidism? It's basically an earlier, a mild form of underactive thyroid. It's called as subclinical. It's basically a biochemical diagnosis. A patient or a woman may not have any symptoms at that time. It may be routinely tested, when a woman comes to us with infertility, it's a routine that we do a thyroid profile. It may be accidentally picked up during that time. Basically, what happens is it leads to raised levels of serum TSH above the accepted laboratory reference range and maybe free T4 and T3. So high TSH and Normal T3, T4 is what exactly is subclinical hypothyroidism. It's generally asymptomatic and may represent the earliest stage of thyroid dysfunction, which has a potential to progress to overt disease. Not in everybody. We will see what are the risk factors where it will convert or has a potential to be converted to overt disease for the future. So the definition differs definitely between the non-pregnant and the pregnant state. And again, there are a lot of, I will discuss some guidelines also. The American Society, the British Society, the Indian scenario, they have a little different cutoff as to who should be defined to have subclinical hypothyroidism. So it is generally defined when the TSH is above 4 to 4.5 milli-IU per liter. It's controversial, again, I'll discuss. But we also know that TSH greater than 2.5 is diagnostic of subclinical hypothyroidism during the first trimester of pregnancy. So the ranges may vary whether the woman is pregnant or not. So for pregnant women, anything more than 2.5 with normal T3, T4 could be a subclinical hypothyroidism picture, whereas a woman seeking fertility treatment, not pregnant yet, trying to get pregnancy, the level of 4 to 4.5 with normal T3, T4 could be classified as subclinical. Often asymptomatic, but some may experience mild symptoms of hypothyroidism. So the first trimester, upper limit of normal is 2.5. Second trimester, it is generally 3. In the final trimester, it is 3.5. But again, this is from the international guidelines. I will discuss the Indian guidelines and what kind of they define as in the end, but this is from the international data. So what is the incidence? Again, it all depends on what is the cutoff we are going to have for TSH. It can vary anywhere between 4 to 8% to as high as 14%. Having said that, 95% of individuals without evidence of thyroid disease can have a TSH levels of less than 2.5. So this is a study from India, from the North India, which is Delhi, where the incidence of subclinical hypothyroidism was 13.5% with a positive anti-TPO antibodies of 18%. Overt hypothyroidism was 7%, and other dysfunctions were less. This is another study from India where the incidence of subclinical hypothyroidism was in total of 25%. In females, it was around 12%. So this is the international data where they looked at 704 infertile women, and the incidence of TSH, high TSH was 2.3% in one of the studies. In one of the Finnish studies, it was 4%, and Argentinian study is 14%. So we can see a wide variation in the incidence, and that's all because of the cutoff every study has used to define as high TSH values. So high prevalence, obviously, of thyroid dysfunction is associated with, whether it's a vice versa or so, it is associated with ovulatory disorders, followed by unexplained infertility and endometriosis. So these are the special high-risk groups where we do see thyroid dysfunction more as comparison to population which has less. So if we just summarize globally, the incidence is 3 to 15%, whereas in India, it has been reported as high as 30%. So somewhere down the line, either we are kind of defining subclinical more than 2.5. If we take about the population between 2.5 and 4.5, maybe our incidence may come to 11 to 15%. So why are we worried about it? Is it associated with infertility? So this is a study from 2017 where they found that there was no association of subclinical hypothyroidism with infertility. And there's another study from Britain with 2021. They found that women with TSH level of less than 2.5 and the levels between 2.4 and 4.5, they had very similar outcomes. Not outcomes exactly, the infertility when compared to the normal population. There's one other low-quality retrospective study which was done in 244 women with infertility compared with 155 women with confirmed, and sought to evaluate the prevalence of subclinical hypothyroidism in these two groups. and it was diagnosed in 13.9% of the women with infertility versus 3.9. And so this study suggested that yes, the infertile population had a relatively higher incidence of SCH as compared with, but the flaw of this study was that this 3.9, obviously in infertility, when they come over, we do it in every patient as a baseline. Whereas in the control group, the testing was only done when they came with some sort of symptoms. So we don't know whether this comparison is really true or not. So is there a link between serum prolactin and TSH, and fertilization link and thyroid dysfunction? So because when we kind of undergo, IVF, and so do we see any difference in the embryo formation, in the fertilization rate? So there it was found that with the prolactin or TSH, in this particular study, prolactin or TSH was taken in 509 specimens collected prior to therapy. And what they looked was the outcome for the couples undergoing IVF between 1994 and 2001. So higher TSH concentrations in their study was shown to be a predictor of fertilization failure in women undergoing IVF. And this was the study. After this study, I think we all routinely started looking at it a little more proactively, the thyroid. And hence it supports an important role of thyroid hormones in oocyte physiology. The TSH concentrations were found to be reportedly significantly higher among women who produce oocytes that fail to fertilize. Among women who had at least one oocyte inseminated, the likelihood of having less than 50% of their eggs fertilized was independently related to higher TSH concentrations. But the mean TSH value taken in this study was 5.1 and not the values what we are talking about. So 5.1 in our population, we call it as overt, and hence we treat them. So, but this study, as per their parameters, they did conclude that high TSH concentrations may predict poor fertilization rates. So this study, maybe it's more good if we want to look at the outcome for the overt one. But in this particular study, they defined the subclinical group as 5 and 5.1. So let's say what happens talking about, infertility. Yes, it may or may not, bring any change. Like we said, the majority of the study says infertility not, but do they cause any pregnancy harm? Let's say if the pregnant patient comes with a high TSH and a normal T3, T4 values, is there any damage to the fetus which can happen? So between 1993 and 2013, 16 observational studies were published, which examined the association between subclinical hypothyroidism and adverse pregnancy outcomes, i.e. miscarriage, fetal death, gestational diabetes, hypertension, eclampsia, abruption, and low birth weight. For each of these outcomes, most studies failed to show a significant association between SCH, then demonstrating a positive association. So largest cohort to date published in 2017 showed that a woman with single TSH pre-pregnancy level between 4.29 to 10 had an increased risk of adverse pregnancy outcomes. So very important that any level between 4 to 10 definitely can be associated with adverse pregnancy outcomes and need controlling, including outcomes such as spontaneous abortion and preterm birth. So, and the reason I think we all know this, that the baby's thyroid hormones are building up after 10 to 11 weeks of gestation. And hence the mother's free T4 is essential to kind of cover the baby's thyroid hormone. And hence a drop is seen. But if there is a kind of a peak in mother's TSH, then it's more of a reason that we treat it with thyroid. So proper management of TSH level is essential to prevent complications such as preterm birth, preeclampsia, miscarriages, and development issues in the fetus. So yes, pregnancy outcomes, we see better outcomes if we treat subclinical. Infertility, maybe not. So preconception counseling and control of TSH is important anyway, because patients who come to us for infertility treatment, it's important that we monitor them. If they are definitely more than 4.5, we need to treat them. If they are between 2.4 and 2.5 to 4.5, what to do, right? So that's the next question, whether we treat or not to treat. And let's see what we should do. The next step is to come on to answer this dilemma. I would say that, it's better to do anti-thyroid antibodies. So now what it has shown is that let's just understand what exactly is anti-thyroid antibodies. Basically, they're autoantibodies which target thyroid proteins, indicating autoimmune thyroid disease. Its prevalence is found to be between 10 to 20% of the general population, more common in women with increasing age. They describe the presence of circulating anti-thyroid antibodies. There are mainly three kinds of antibodies: thyroid peroxidase, thyroglobulin antibodies, and receptor antibodies. Of the three, the most important is thyroid peroxidase antibody. It is the most sensitive marker for detection of thyroid autoimmunity. These are just the levels I thought I'll keep. So thyroid peroxidase antibodies most commonly associated with Hashimoto's thyroiditis and Graves' disease. Thyroglobulin antibodies mainly with Hashimoto's as well, and receptor antibodies mainly with Graves' disease. So how can it help us to predict the outcomes? It has been shown in various studies that yes, pregnancy complications may increase. These women can have fertility issues. Now, this is a separate subgroup where there is a subclinical hypothyroidism, maybe the levels between 2.5 to 4.5, and have positive autoantibodies. If they don't have antibodies, then are they at risk? I think we already studied that maybe not. If it is just the TSH value, we should not worry much about the fertility issues. They can also lead to maternal complications like development of hypothyroidism, miscarriage, preterm labor, and fetal complications like low birth weight and neurodevelopmental delays. What's the evidence? The data is very mixed. The prevalence of isolated thyroid autoimmunity body may be as higher among infertile women, and especially when infertility is caused by endometriosis or ovulatory dysfunction. So in a prospective study comparing 438 infertile women and 100 age-matched healthy fertile controls, the prevalence of antibodies was 18% in infertile women compared with 8% in the control population. Although anti-thyroid antibodies are not used for diagnosis of SCH, which is subclinical hypothyroidism, but they're often measured and elevated and have been found to have an associated risk of conversion of subclinical hypothyroidism to overt hypothyroidism later in the life. So again, if we do thyroid antibodies, it just gives us little extra information whether she may have an incidence of overt hypothyroidism, and secondly, whether we may expect any untoward fetal complications once she gets pregnant. So I think it's worth doing this level, especially in subclinical where the levels go more than 4.5. We know that she may not, between, I would say, 2.5 and 4.5, where we feel she doesn't need treatment. But again, she's got a history of infertility. She's got a history of maybe endometriosis, of ovulatory dysfunction. I think it's just we should have a little low threshold of measuring for thyroid antibodies. The prevalence of thyroid dysfunction and autoimmunity in women with history of miscarriage or fertility, again, the data supports this, that the presence of thyroid antibodies was associated with history of miscarriages, especially in women. They also did a subgroup analysis where they looked into the BMIs, and women in obese classes were statistically significant and more likely to be TBO positive compared with women with a healthy BMI. So do thyroid antibodies make any difference? Evidence of increased risk associated with thyroid antibodies in women with SCH is limited, but stratification of outcome data by antibody positivity in a prospective cohort study revealed an apparent increase in the risk of miscarriages. So it's worth looking into it and treating it if the antibody levels are high. This is a study where it was a single-blinded randomized controlled trial of thyroxine given to women with thyroid peroxidase antibody positive, and they did demonstrate a reduction in preterm delivery for women with an initial TSH of more than or equal to 4 milliunits per liter as compared to less than 4. So yes, maybe we can avoid pregnancy complications if it is subclinical hypothyroidism, levels between 2.5 to 4.5, and with the positive thyroid antibodies. So let's say what the guidelines recommend, recommendations worldwide and from India are. So this is the guidelines from India, what I said that, if the levels are less than 2.5, or if they're less than in the first trimester, or if they're less than 3 in the second and third trimester, no need of any treatment. If the levels are between 2.5 in the first trimester, 2.5 to 10, or between 3 to 10 in second and third trimester, it's better to start L-thyroxine per day of 25 mcg. Maybe we don't need treatment in the postpartum period. It's good to measure it, but maybe she may not need any treatment after delivery. Third scenario, where the levels are more than 10 milli-IU per liter in all the any of the trimester, she should be on 50 mcg L-thyroxine. And this woman may need continuation in the postpartum period, or we may do antibody testing to predict whether she will need treatment maybe lifelong throughout her life. Pregnant women on treatment for hypothyroidism before pregnancy, if she's already on hypothyroid treatment, L-thyroxine dose may need to be modified according to levels mentioned here. Pre-pregnancy dose of L-thyroxine to be continued in the postpartum period. So if you modify it, I think it's better monitor the levels and let them go into their pre-pregnancy thyroxine levels. What does American Thyroid Association says? It says that pregnant women with TSH concentration more than 2.5 should be evaluated for thyroid peroxidase antibodies. If they're positive with a TSH greater than pregnancy-specific reference range, the thyroxine therapy should be indicated. If they're TPO antibody negative, but TSH greater than 10 milli-IU. So they are not treating anybody if until unless the TSH values goes more than 10. I don't know whether it's right or wrong, but if they say that if the antibody status is negative, we can wait, monitor them, and then if it goes more, then obviously this is not what the Indian guidelines are saying. So there's little contra. That's why I brought it here, because there's a little difference in what the Indian scenario is and what the international guidelines are. So TBO positive women with TSH concentration more than 2.5 and below the upper limit of the pregnancy specific range, the thyroxine therapy should be considered. And if it is so I think this is just a repetition. So thyroxine therapy is not recommended for thyroid peroxidase negative women with a normal TSH within the pregnancy specific range, which means less than 4. So their cutoff is 4. And so this is for the patients who are trying to get pregnancy and or pregnant. If the levels are less than 5, she's TPO negative, then no need to treat her. What about the American Society for Reproductive Medicine? They say that subclinical hypothyroidism as a level, TSH greater than 4.5 to 5. The upper limit in most laboratories is 4 for non-pregnant and 2.5 in the first trimester, which is equivalent to what our Indian scenario is. A lot of kind of a controversy and insufficient data that SCH is associated with infertility. But there's a fair evidence that SCH more than 4 can be associated with miscarriages. But again, 2.5 to 4, like I said, is a gray area. Fair evidence to say that TSH more than 4 during pregnancy can be associated with adverse outcomes, and a reasonable kind of a thing to start them on thyroxine therapy. Currently available data support that it is reasonable to test TSH in infertile women attempting pregnancy. If concentrations are over the non-pregnant lab reference range more than 4, they should be treated with levothyroxine, and the target should be to keep the levels below 2.5. Given the limited data, if TSH levels prior to pregnancy are between 2.5 and 4, monitoring, and when the TSH level goes more than 4, or maybe you can test antibody levels in them. Again, it's a gray zone. What they say is thyroid antibody testing is not routinely recommended. One might consider testing TPO antibodies for repeated TSH values more than 2.5, or when other risk factors for thyroid disease are present. If TPO antibodies are detected, TSH levels should be checked and treatment should be considered if TSH is more than 2.5. So just a little slide, one slide on levothyroxine therapy. Treatment decisions should be individualized. It's not something, we should just give it. Consider age, cardiovascular status, symptoms, and risk factors. Even though there have been no long-term, adverse effects or trials, in fact, conclusively evaluating the impact of levothyroxine on cardiovascular and mortality in elderly patients. But we should be cautious and we should only give when it is indicated. So take home messages, we need to be aware when to treat, when to test. We should manage it appropriately, not rampant administration of thyroxine, but also at the same time, not missing is also important. And we should be monitoring our patients regularly if they are found to have, fluctuating thyroids and antibody positive. To summarize, there's a wide variation in clinical practice. As we already said, that SCH, again, difference in infertility, difference in pregnancy outcomes. I think by now we remember these ranges. 2.5 is more than 2.5, when to treat, when to test. However, given that there appears to be benefit in some subgroups and minimal risk, it is reasonable to treat even though the evidence is weak. So again, this is just the American Society of Reproduction summary, when to treat and when not to treat. So I think that's all where I end, and happy to have questions if there are any. Thank you.
Thank you, Dr. Puneet. I really loved your slide, which showed the antibodies, TSH and HCG, and the post receptor things that are happening in the cell. Because we are usually taught one hormone, one receptor, it binds. But this
Yeah.
cross reactivity is something we have to get our heads around it, that there might be other ones that are stimulating it. So,
Yeah, and very rightly, Dr. Padma. I often get a call or somewhere from our juniors and everything that, she's pregnant, she's got TSH, which is low. She's got a borderline high free T4. Shall we reduce, if she's on thyroxine, shall we reduce the dose? Shall we not reduce the dose? I mean, and I think we should not, because the strict thyroid control is very important at this time. A slight amount of high free T4, maybe because she's got HCG in her blood and HCG is cross-reacting with those antibodies. So we should not be kind of rushing into kind of dropping or increasing her doses too much, especially during the first trimester, till the 10 weeks. A strict control is important till the baby's thyroid hormone is taking over. Yeah.
So, and I think the simplest thing will be to do a TSH and an antithyroid antibody. Let's forget about the T3, T4. Just do these two if financial constraints are there. Then it makes so much sense and it is so easy to decide.
True. Very true. Yeah.
Yeah. Thank you for the lovely talk.
Thank you.
We don't seem to have question. In which patient would you do antithyroid antibodies? This was one question from Dr. Sandeep.
So, like I mentioned in my slides, that again, if the levels are less than 2.5, you don't need to, right? If they are between 2.5 to 4.5, right, then you may, like Dr. Padmaja said, that there are financial constraints. You can tell them that in case you do thyroid antibodies, what will be the advantages? Whether there's a chance that she's going to have overt hypothyroidism later in life, whether she's going to develop hypothyroidism in pregnancy. So you can talk to them and advise them. But if it is, again, also when you want to decide whether you want to put her on levothyroxine or not, because if she is between 2.5 to 4.5 and her antibodies are positive, she definitely needs to go on thyroxine, right? And if she has associated condition like endometriosis or ovular dysfunction, then also I think you should advise thyroid antibodies. And because she needs a good thyroid control, because I had a patient, I remember, where her thyroids would just jump so much in the luteal phase when we would do her embryo transfer after IVF. Her TSH would go rocket high 15, 16, 17. So we were doing and in the beginning, we never did antibodies. But when we did her antibodies, it came very high. So we kind of adjusted her dose in the luteal phase, in the follicular phase, because these group of women do need a strict thyroid control. So if your woman is undergoing like recurrent miscarriages, or she has endometriosis, she has a borderline thyroid TSH between 2.5 to 4.5, you just need more answers. So you talk to them and get them done.
Thank you, Dr. Puneet, Dr. Padmaja, for the very enlightening discussion that you initiated. And Dr. Puneet, you have given such practical messages and so crisp and so clear. I'm sure all of us have really benefited from that. So with that, we move to the next leg of our event today, and that is the quiz. Um, so for the quiz, we would be having Dr. Sajjad to be taking the quiz in Kahoot. And just a brief
Puneet,
word.
can you stop slide share? Thank you. Yeah, thanks a lot. Thanks a lot. Yeah, please.
Yeah, thank you, Dr. Puneet. And before Dr. Sajjad takes on with the quiz, I would just like to briefly go over the way the Kahoot works. I hope all the candidates who are here with us for the quiz, they have Kahoot downloaded on their mobiles or computers or whatever. So there'll be a number which will be flashed on the screen by the admin team, and you got to put that number in the Kahoot app. And as soon as all of you are in, we would be locking the Kahoot room. And I would request all the candidates to be joining by their mobile numbers and not their names. Everybody, please rename the joining as their mobile numbers so that we can get back to you whenever we need. And one more important thing is that in Kahoot, the speed as well as the accuracy matter. So we would be able to judge you guys about who answers quickest and most accurate. So I think you all are familiar with these rules. So over to Dr. Sajjad.
Yeah, I hope all the participants have opened their Kahoot app. So let them enter their password as by, this 9136855. We have to enter in the Kahoot app. So there will be 20 questions in total. Out of these 20 questions, 10 questions will be from the endocrinology and 10 questions will be from the PCOS. So I request everybody to keep in mind the speed and accuracy of the answers. So it is good that everybody should convert their names with the phone number so that we can connect with them afterwards, because we have to give the certificates afterwards. Everybody should keep in mind that we have there 3 winners. That is number 1, number 2, and number 3. And there will be 2 runner-ups, number 4 and number 5. So for that, we have to connect with the participants who will be number 1, number 2, number 3, number 4, and number 5. So I think everybody's coming. So there are only 6 people. All the participants who are interested, they should open the Kahoot app. And after opening the Kahoot app, they have to give the number. This number is there on the screen. PIN number 9136855. So that they can participate in this quiz.
So I think 1 or 2 minutes more, we should be locking the room and setting off. What do you say, sir?
Yeah. There are only till now there are only 6 participants.
One of those participants is me, because I'm giving it a run.
Oh, there are only five. Five were already with three winners and four runners-ups.
So if Dr. Padmaja wins, then she doesn't qualify for the prize.
Yes.
Yeah.
So I think we get going, should we?
There's one
Dr.
person
Gawar wants a
to
Yeah.
nominate.
Yeah. Let us wait. Let's wait. One person he's going to come.
Yeah.
Mr. Dr. Gawar Ajaz. Cohort app. Download. You have to first download the Cohort app. So if anyone cannot change the phone number of their ID, they can just come through their own names. Then afterwards, maybe we will get their contact numbers. They can enter through their own, they can enter through their own names. There's no problem. Maybe after the quiz, we will get their numbers. If there's any problem,
Dr. Gawar is also in. Okay, yeah, we're getting
8.
Surprisingly, I have been getting queries from so many people from all over the country about where is the next quiz. And I thought that we should be having at least 25 to 30 people. It's quite disheartening to see such a small number.
I think maybe they cannot just convert their ID into their phone numbers. Let them come to through their IDs which they are already having.
Of course.
Because some people are
Yeah,
not
you have
aware
told
of
them this. Yeah, that's a good idea.
So we can request each and everybody, they can come through their own IDs, whatever they are having.
I think we give them 1 or 2 minutes more and then we get off.
Yeah, we should. प्ले में करो ना कोहट ऐप डाउनलोड प्ले स्टोर
Sir, I think we should start. Sir, I think we should start. It's 8:30.
We should start 7.
I think
it's getting logged. Okay, fine.
Let's start. Start. Yeah, now we have started. So first question is primary function of theca cells of ovarian follicle. So we have to keep in mind the speed and accuracy of these answers. 7 people have answered, and all 7. Yeah. Second question is number of oogonia by 16 to 20 weeks in human embryonic ovary. There are 4 choices: 9 to 11 million, 7 to 9 million, 6 to 7 million, 4 to 6 million. Yeah, 6 to 7 million it is. So 3 people have answered right. Top is third question. AMH is produced by theca cells, granulosa cells, adipocytes, mesonephric duct epithelium. Yeah, which enzyme converts testosterone to DHEA? Aromatase, 17 beta, 5 alpha reductase. 5 people have answered. Next question is the hormone DHEAS is synthesized by ovary, testicle, adrenal gland, pituitary gland. 7 people have answered adrenal gland. Okay, right. Sixth question, the earliest morphological evidence of ovulation on endometrial biopsy. Pseudostratification basal evacuation, yeah, decrease in basal evacuation. Five people have answered right. And the top scorer is 80098272288. Seventh question, just before ovulation, there is LH surge, FSH surge, LH and FS surge, none. Yeah, three people have answered right, LH and FSH surge. So here 80098272288, it is scoring right. Eighth question, in which of the following conditions do ovaries function normally? Turner syndrome, Kuster-Hauser syndrome, androgen insensitivity syndrome, Sears syndrome. It is Kuster-Hauser syndrome. MRKH. 80098272288. It is top scorer. So false about precocious puberty is number 1, secondary sexual characteristics before 10 years. MRI brain, commonest cause is idiopathic. MRI brain is recommended. Earliest sign of precocious puberty is in boys is increasing testis size. So secondary sexual characteristics before 10 years. It is right. 4 people have written. So the 80098272288, it is scoring highest scorer. 10th question out of the endocrinology. Which enzyme is present in granulosa cells but not in theca cells? 11 beta hydroxylase, 17 beta aromatase, acid phosphatase. Yeah, 3 people have answered right. Aromatase. It is. So the scorer continues the same. 80098272288 with 8176 is highest scorer. So now it is now PCOS. From PCOS, by definition, lean PCOS is diagnosed when BMI is less than 20, BMI is less than 25, weight less than 50 kg, waist circumference less than 80 centimeter. So 6 people have answered right, BMI less than 20. The same number is the highest scorer. 12th question out of PSO. First line of management of lean PCOS is lifestyle modification. The patient is accordingly advised to gain weight, lose weight, maintain weight, reduce physical activity. Maintain weight, yeah. So 5 people have answered right. So the scorer the same. Now 9949734322 is the highest this time. When women with lean PCOS are different from their obese counterparts as number 1, generally don't have acne, generally don't have excessive facial hair, are unlikely to have oligoovulation, apomenorrhea, metabolism arrangements are less severe in lean women. Yeah, 6 people have answered right. Metabolic arrangement. So the scorer again the same person. 80098272288 now topping this list with 9955. 14th question, investigations which can differentiate delayed onset CAH from lean PCOS include elevated early morning basal 10 OH progesterone, post ACTH 17 OH progesterone level more than 43, genetic mutation analysis, all of the above. Yeah, all of the above. 4 people have answered right. Again, 9949734322, topping the list. So 15th of question is, which of these is not an essential prerequisite before starting induction of pollution in obese women with PCOS? BMI 25 to 27 kg per meter square, hypertension controlled with schedule AB drugs, diabetes well controlled with metformin or insulin, clinical examination to ensure good overall general health. Yeah, 4 people have answered right. BMI 25-27. So the same 9949734322 topping. So 16th question, when are gonadotropin is considered for ovulation induction in PCOS? As a first line agent in obese insulin resistant women, when she fails to conceive after 3 to 6 cycles of letrozole, as a first line agent in women with associated endometriosis, used for IF cycles only. Yeah, 6 people have written the correct answer, and she fails to conceive after 3 to 6 cycles of letrozole. So again, the same number is topping the list. Now 17th question of 20. Which of these best describes terminal here? Pigmented hair more than 3 mm in the forearms, legs. Pigmented modulated grow more than 10 mm if left intact. Pigmented modulated grow more than 5 mm if left intact. Non-pigmented hair in the 9 androgen dependent sites. Yeah, 4 people who was correct answer out of those 99. Now the other person is topping the list, 99497. So 18th question is, which of these is not recommended for the treatment of mild acne? COCPS, benzoyl peroxide, topical clindamycin. 3 people have written the correct answer, COCPs. So the same number, 99 is continuing to top. 19th question is, which of these anti-androgens act by inhibiting peripheral androgen conversion? Spironolactone, flutamide, steroid, all of the above. Finasteride, 3 people have written the correct answer. So same number is continuing to top, 9949734322. So the last question of this quiz is, open comedian donors are commonly known as whiteheads, blackheads, pustules, nodules. Yeah, 2 people have written the correct answer, blackheads. So we will request the person who has who have topped the list and who will be the top 5. So the top number 1 is with 13931.16 out of 20. This is the number 800982728. Number 2 with 13687, 17 out of 20. She had qualified. 9949734322 number, telephone number. And position number 3rd, 7464993020. with 10688 score. 14 out of 20 questions, the person, he or she answered.
Himanshu, thank you, Dr. Sajid. Himanshu, take out the number 2, that is mine. So you'll have to disqualify me.
Okay.
You give the other 5. Okay.
So hi all. I was unmute till now. Now, so I would like to thank Dr. Sajid for conducting a great quiz, and Dr. Manjusha and Dr. Padmaja for a great discussion, and also our great speakers, Dr. Neeti Tiwari and Dr. Puneet Arora, for giving this such an informative presentation. And these two topics were very important in our day-to-day practices. And most important announcement I have to make, the next topic will be on endoscopy. Quiz will be on endoscopy and date will be on 17th April. That is the third Thursday of next month. Thank you.
So thank you, everybody. Thank you.
Thank you,
Ma'am
sir.
Manjusha.
Before we close, sir, we want the 3 winners. So since Dr.
Yeah.
Padmaja has to be deleted, I
Yes.
would request the admin Himanshu ji to find out who the 4th winner is so that we can make him 3rd, him
Okay,
or her.
let me
Yeah.
share.
And the winners can share their email ID and their names with phone numbers to Dr.
Yeah.
Manjusha.
Yeah, it's very important because we
Yeah.
need to be recording the names and maybe we will be sending your e-certificates.
They
Yeah.
can write their names on the message on chat box also.
Dr. Parul, I
Yeah.
think last time we sent e-certificates to 1, 2, 3, right?
Yeah, first two winners. Only first two winners.
No, e-certificate.
No, we have 3 winners actually. Number 1,
Yeah.
number 2, and number 3, and 2
E-certificates we
runner-ups.
have been sending to 3
Number
actually.
4 and number
3?
5.
Yeah, I think
Yeah,
so.
number 2 is omitted. So then we have 2 winners and 2 runner-ups.
So whatever, we need 1, 2, 3, 4, 5 if possible from the admin team. And then we can be deciding as to. Yeah, okay.
Yes,
Okay. So let me just take a click of this. Okay, thank you so much. Thank you.
Thank
So-
you. Good night, and we had a wonderful time.
So I think it has been a lovely session. Thank you all for being with us. And we really look forward to seeing you guys again with greater numbers, of course, in about 4 weeks from now. Thank you.
Thank you.
thank you.